Good afternoon, and welcome to our first lecture of this year for the Ethics Center. I'm Catherine Brown-Saltzman. I'm co-director of the Ethics Center. And as many of you know, we focused a couple of our lectures on the End-of-Life Option Act to really create awareness and a little bit more education and really encourage discussion about the ethical components of the Act. So I'm delighted to be able to introduce Dr. Daniel Sulmasy, who is from the University of Chicago. He's the Kilbride Clinton Professor of Medicine and Ethics in the Department of Medicine and Divinity School there. He's also the Associate Director of the McLean Center for Clinical Medical Ethics. And I just want to say that that is one of the premier clinical ethics consult services in the country with a fellowship program as well. He has expertise in general medicine, general internal medicine, as well as a particular interest in end-of-life care. He's a member of the Presidential Commission for the Study of Bioethical Issues, and as an ethicist and practicing physician, Dr. Sulmasy studies end-of-life decision-making, ethics education, and spirituality in medicine. In addition to serving on editorial boards of several academic journals, he is editor-in-chief of the journal Theoretical Medicine and Bioethics. And he previously served as chair of the Ethics Committee of the Society of General Internal Medicine and on the board of directors for the American Society for Bioethics and Humanities. He's a prolific author and speaker. He's lectured on ethics and medicine extensively throughout the United States and Europe. And he is the author or editor of 6 books and has written more than 200 peer-reviewed articles, journals, on topics such as ethics of stem cell research, physician-assisted suicide, and informed consent and surrogate decision-making. So we welcome Dr. Sulmasy, and I want to remind you all there's also an evening public lecture, the Litvak public lecture this evening with a reception at 6 o'clock. And following that, a lecture at 7. So again, please warmly welcome Dr. Sulmasy.
Well, thank you for that gracious introduction. Thanks to all of you for coming here today. It's good to be with folks I know, like Neil Wenger, and I got reacquainted with Joe Rajo as well. I have to start with a disclaimer. You heard I'm a member of the Presidential Commission for the Study of Bioethical Issues. These are my views. You should know not that I'll be presenting today, not those of the Commission. And, you know, for CME purposes, I have to give you my disclosures. I'm a general internist and a philosopher. I spent the first 25 years of my life as a Franciscan friar under a vow of poverty. No manufacturers of drugs or medical devices actually have ever been interested enough in anything I have to say to give me any money. I own no stock in any corporation other than 1 share of the Green Bay Packers and 3 shares of the Seminary Book Co-op. I have no relevant conflicts to report. The topic for today is a very controversial one. I realize that, and it evokes passionate feelings on all sides. I want to urge us to think about these issues, though, not just to emote about them, and to think as clearly as we can. I don't want us to ever discount our emotions, but to recognize that we ought to judge those emotions and find out which ones are good and which need to be contextualized in view of our ethical deliberations. Above all, I want to invite respectful dialogue about this very controversial issue. And please don't shoot me if you disagree. You're going to have another speaker coming in a few weeks who will take the opposite point of view on this topic. But I wanted to start by giving you a little bit of history. Certainly the topic is not new. Ancient Greeks and Stoics, actually there are quite a few of the philosophers there who were favorably disposed toward euthanasia and assisted suicide. Hippocrates came at a time that it was probably the case that there was a fair amount of assistance in suicide, or people have thought perhaps even more surreptitious killings of patients by physicians who would poison them. And the Hippocratic Oath, as you know, stands opposed to that. And the Hippocratic physicians distanced themselves from the physicians of their day to start a kind of new ethical standard that for most of the last 2,500 years of Western medicine has stood. Jews and Christians embraced this rejection of euthanasia and assisted suicide. There have been a few wrinkles along the way in Western history. John Donne, many of you probably don't know, wrote a whole book on suicide called Thanatos, and it was only able to be published posthumously because it was so controversial after he died. And David Hume, actually, is a philosopher who began to really severely critique the Western prohibition on suicide. There was, many people are not aware, and just to bring you back into history here more recently, an early 20th century euthanasia movement, particularly in the U.S. and the U.K., and there were bills introduced, for instance, in several legislatures in the United States to legalize euthanasia. This was very tightly linked to the eugenics movement, and when the Nazis applied this to the involuntary euthanasia of retarded persons and persons with mental illness, any attempt to legalize euthanasia or assisted suicide in the United States just dropped off the map when we got wind of that application. Bring us more up to date in very recent history. Euthanasia in particular and some assisted suicide began to be tolerated legally in the Netherlands, even though it was still on the books as illegal in the 1980s. It was finally legalized in the year 2000. You may remember Jack Kevorkian, who used a machine called the Mercitron to popularize assisted suicide. Timothy Quill, a palliative care doctor from New York, actually wrote about it in the New England Journal of Medicine, starting great controversy, then brought a case of trying to legalize it, saying it was against the constitutional rights of patients to not have access to assisted suicide. That was decided by the Supreme Court in 1998, ruling against Quill. There have been referenda in at least two states in the United States, Oregon in 1997 and Washington State in 2008, which legalized assisted suicide. By legislation, Vermont first in 2013 and your own state of California in 2015. There's been an awful lot of other action in states and state legislatures, as you may know. Even in California, there were two referenda previous to the legislation and multiple attempts before it was successful to legalize it through legislative action. All these other ones have been rejected by all these other states. State courts in Montana, the Supreme Court ruled that physicians and patients were protected from prosecution if they did this, and there's no real legislation of any sort and no referenda. And the state of New Mexico, many people heard about the fact that there was a lower court decision that stated that it was against the state constitution. Just recently, the New Mexico Supreme Court ruled that there is no constitutional right in the state constitution of New Mexico to assisted suicide. Internationally, following the Netherlands, Belgium legalized PAS and euthanasia in 2002. In Switzerland, assisted suicide has been legally tolerated. It's done not by physicians, but by other persons. In Australia, briefly, from 1995 to 97, in the Northern Territory, euthanasia was legalized, and then it was quashed by the federal legislation. And then, again, last year, the Canadian Supreme Court declared there was a constitutional right in Canada to assisted suicide and euthanasia. So that's the history we have most recently. The current U.S. playing field is this, that the U.S. Supreme Court has decided that laws banning assisted suicide are constitutional. There's no provision within the U.S. Constitution that says patients have a legal right to assisted suicide. What the Supreme Court also stated, though, was that states were free to pass laws that would legalize it if they so chose, and that's what's happened in several other states. Euthanasia remains, which is an act in which the physician actually performs the lethal act, typically by a lethal injection, is illegal in all states in the United States. 31 states currently criminalize physician-assisted suicide by statute. It's generally assisted suicide of any kind, so it can't be the family assisting someone either. 9 states have criminalized it through the common law. Virginia imposes civil but not criminal sanctions for this action. 4 states people think are ambiguous. Montana I talked about, and then Vermont, Oregon, Washington, and California are legal by statute, as I just stated before. In the face of this, I think you may have seen some of it, but I don't know that you all know what happens behind the scenes while you're busy taking care of your own patients. But there is a continuous, relentless national political movement promoting at least assisted suicide, if not euthanasia, done mostly by Compassion and Choices, which when I was appointed to the Presidential Commission for the Study of Bioethical Issues, they were the only people who took notice of it and put out a press release condemning my being appointed to the Presidential Commission for the Study of Bioethical Issues. I mean, no one else even noticed, But I'm on their radar. Everything that's about assisted suicide is on their radar. They're very well funded. A lot of money from George Soros, $15 million in 2015 in donations. And they have lots of grassroots support. Court actions have been taken up, state constitutional challenges in many states. Just in the last year, 22 bills were introduced in state legislatures through the U.S. All were defeated, and almost none of this gets reported. Almost none of the negative activity gets reported. So you hear the New York Times, reports on the Montana ruling, but you have to get to the Hartford Courant to find out that it's been rejected by the courts in the state of Connecticut. There was more publicity, I will say, about the referendum in Massachusetts a few years ago that rejected assisted suicide. And just this year, a bill that died in committee, you have to go to something like the Denver Post to get a very small article saying that that was rejected by their state committee. Again, just to be clear, let's go through some definitions. This will be helpful for the rest of your series of lectures. Voluntary active euthanasia is the term that most people use, and I will use, for an action in which the physician is the agent of the lethal action. Again, typically by injection. Sometimes it could be by inhalation, but the physician is the person who does, or someone else in general, but typically a physician will do the action. That's euthanasia, and it's typically voluntary if the patient has decisional capacity and says that they want it. And this is what the majority of the cases are, for instance, in Belgium and the Netherlands. Non-voluntary active euthanasia, again a term of art, doesn't mean involuntary. It simply means the person has never stated whether they want it or not, but someone has construed that the person, or any reasonable person, would want it in this case, and then they perform an act of euthanasia. And as I'll talk to you a little bit later, this happens with some frequency in other countries. Involuntary active euthanasia is the person says, "Don't kill me," and somebody does. Most places that's still considered murder, and it's not typically done. But this same phrase of the same term of euthanasia is used in many by commentators on this. The term passive euthanasia is sometimes used for withholding or withdrawing life-sustaining treatments. I think it's confusing. I think allowing to die is the better term under those circumstances, or the withholding or withdrawing of life-sustaining treatments rather than passive euthanasia. In contrast to these, assisted suicide, the patient is the agent of the lethal action. So the patient is given assistance in bringing about his or her own death, and that's typically done by pills, but could be done by any other means. Dr. Kevorkian used to ask patients to push a button that would give them carbon monoxide, and that was, again, a lethal action, but it was assisted suicide technically because the patient pushed the button, and all Kevorkian did was to set everything up so that it would work for bringing about their death. That's assisted suicide. The patient does the action. Now, what are the moral arguments in favor of this? And again, I want to emphasize that I'm going to talk about the ethics of these questions. And here's how I would characterize these arguments. They're the argument from mercy, the argument from dignity, the argument from liberty, and what I'll call the argument against sophistry. I think those are the main sets of arguments you'll hear in favor of legalizing at least physician-assisted suicide. The same kinds of arguments are often used for euthanasia, but we'll limit our discussion to assisted suicide. The argument from mercy is this. You've maybe heard people saying, we treat our pets better than we treat our patients, right? If a pet is suffering, and that suffering seems to be excruciating for the pet, you bring the pet to the vet, and the vet will euthanize your dog or cat. And they say if we can do that for animals, why aren't we as merciful to human beings? The British often come up with what they call burning lorry cases. Let's suppose someone, the lorry is the British term for a truck. Somebody's in a burning a truck, and you can't open the door, and they're either going to burn to death or you can shoot them. Wouldn't the compassionate, merciful thing be to shoot them under those circumstances if you've got the gun? And so people try to come up with what I call medical versions of the burning lorry case. The person with severe refractory symptoms and nothing that can be done will possibly relieve them, and they claim that under those circumstances, which we can debate with how often they actually happen, but they come up with those kinds of cases, wouldn't it be a merciful thing to do to end that person's life, or at least assist that person in ending his or her life? And often it is argued that relief of suffering is the primary goal of medicine. And that's why this is something that physicians ought to be able to do, because when there's no other way to relieve the patient's suffering other than ending the patient's life, we should be able to assist people in doing that if we are merciful as physicians. The second argument in favor is the argument from dignity. There are those who will argue that there are certain states of illness that simply rob a human being of dignity. Often the case that's brought up here would be cases of neurologic conditions, particularly Alzheimer's disease, or let's say ALS, Lou Gehrig's disease, states in which the patient might become incontinent, dependent upon other persons, disfigured, and surely if we are about respecting the dignity of other human beings, we could see that PAS would be sometimes a way to preserve that person's dignity, to let them go out before that kind of thing happens, or certainly at the earliest stages when they've determined that the illness has robbed them of their dignity. The third is the argument from liberty. It's probably the most common argument one hears. It's based largely on J.S. Mill's concept of liberty, that we need as a moral argument to promote the liberty of all persons, limited only by something that would harm others. So that we all ought to have a society in which we are free to do as many things as we possibly can, and the only limit on that liberty ought to be the harm to others. And the argument would be that suicide doesn't harm anybody else except the person who's doing it, and therefore we ought not to be restricting the liberty of that person. It is also sometimes interpreted within the bioethics movement. I trained at Georgetown, so you'll forgive me for calling it the Georgetown mantra of autonomy, beneficence, non-maleficence, and justice as the four principles, that autonomy still is the primary goal or the primary principle, and that out of respect for the autonomy and self-determination of patients, if a patient is determined that he or she wishes to end his or her life, and we are their caretakers from a medical perspective, then we ought to be able to help them to do that. And the argument against sophistry, which is interestingly one of the main ones that was put forth by Quill in his argument before the Supreme Court, and is certainly supported by many philosophers, is that there is no coherent distinction between killing and allowing to die. That if you're prepared to discontinue a ventilator on a patient and you know that the patient is going to die, then you have killed that patient every bit as much as if you gave them a lethal injection. So how can one claim that there is a moral difference between those two things if they are really essentially the same action? And that we ought to be able to allow patients to take their own lives if we will allow them to refuse life-sustaining treatments, and that to make a distinction between these two is sophistical. That we're just fooling ourselves. It's not real. Well, I am someone who is actually, no surprise to you, opposed to the legalization of assisted suicide. I think your law in California is a bad law. And here are some of the arguments that I'm going to give you for the rest of the lecture about why that might be the case. I will argue first that I think killing can be distinguished from allowing to die. And then secondly, that I think from a moral point of view, physician-assisted suicide is bad medicine, bad ethics, and bad public policy. If it weren't for all those, I'd be in favor of it. But I think it violates all of those. So can the distinction between killing and allowing to die be defended? It seems to me that most persons on the street, on first hearing about it, would say, well, sure, there's a difference between stopping a ventilator and giving somebody a lethal injection. And I think the first instinct of most clinicians from a common sense point of view would be to say that there's a distinction between those two. But once one begins to sort of think about it more deeply, people get troubled. So a philosopher named James Rachels actually published a version of this in the New England Journal of Medicine in the 1970s and said, suppose there were two children in a tub, and they had two uncles, Smith and Jones. And Smith stands to inherit $1 million if his nephew dies by midnight. His nephew is in the tub. He pushes his head under the water. His nephew drowns. He arranges it so that it looks like an accident, collects $1 million, and is very happy. I think we would all say that Smith had killed his nephew, right? What Rachel says, well, suppose Jones goes into the room prepared to do the same, but he finds his nephew, from whom he would collect $1 million if he dies by midnight, in the tub, and he sees him slip on a bar of soap, hit his head against the side, fall face down into the water, and he just stands there. A few bubbles come up, and he just stands there. And then his nephew finally drowns. He walks off with $1 million saying it was an accident. Wouldn't we think that it was wrong what Jones had done, even if he had allowed the person to die? So Rachel's argument is, then there can't be any moral distinction between killing and allowing to die because we have two morally wrong cases, one of which is killing, one of which is allowing to die. Okay, you with me? So that's the sort of argument that says there's no difference between these two. What about the difference between active and passive? Maybe that's what you think it is. In turning off in discontinuing a ventilator, or not starting one, you're foregoing a life-sustaining treatment. You're not acting, but in killing, you're actually doing something to bring about the person's death. Well, that doesn't get you very far because it's a motor action, isn't it, to turn off the ventilator or unplug it or to stop the dopamine infusion. You're doing a motor action to do that. So that can't really be what the distinction between killing and allowing to die is either. And what about causation? People might say, well, in allowing to die, nature causes the death, and in killing, it's the doctor who causes the death. But again, it's hard, I think, to just say that by turning off a dopamine infusion, you aren't at least causally involved at some level in the death of the patient. So I don't think that stands up either. So the question arises, this is what the philosophers would do, can this distinction be defended when all of these arguments have been brought up to say that the common sense reasoning of the average person on the street and most clinicians is just wrong. Here's how I think it can be defended. Here's my definition of killing. It is when a person, X, creates a new lethal pathophysiologic state in another person, Y, with a specific intention in acting that that other person, Y, should die by way of that act. It's very complicated, but what it means is persons in their present state of health, from which they are not about to die of anything imminently, and you create a new lethal pathophysiologic state in that person by putting a dagger into their heart or by giving them a lethal injection. You've created a new lethal pathophysiologic state, and the intention is to make the person dead, and then you have killed that person. In allowing to die, we refrain from or we remove an intervention that interferes with the progress of a pre-existing lethal pathophysiologic state in that person. So the person has a lethal pathophysiologic state that has prevented them from being able to breathe on their own, and we either don't put on a ventilator or we discontinue the ventilator. Now we can do so either intending that the person die by way of that act or not so intending. And that makes a moral difference, right, what our intentions are. So here's the defensible form of the distinction. Rachel's is right if the distinction between killing and allowing to die is that all killing is wrong and all allowing to die is permissible. What I think people who defend it actually believe is that all killing is wrong. Maybe they'll make exceptions for self-defense or rescue of someone else. But some allowing to die is morally permissible. There are some cases in which we allow people to die that are morally permissible. Lots of them happen, I'm sure, in this hospital. They happen at the University of Chicago, where I work, where we discontinue a ventilator because we think it's more burdensome than beneficial for the patient. That, I think, is morally defensible. But it is also possible to allow someone to die for immoral reasons. So what if someone comes to the hospital and they're about to give $1 million to the McLean Center at the University of Chicago, and they're in extremis and not able to breathe, and I decide I'm not going to put them on a ventilator. Because if they do, my institution collects $1 million from their will by midnight. I think that would be a case in which what I am doing is intending that they should die, and that's what the bad acts of allowing to die have in common with all the acts of killing. Is that the intention in the action is to make the person dead. The good acts of allowing to die. What we intend is that the treatment should stop, not that the patient should stop. right? What we are intending is that there is a state of affairs in which the patient is disconnected from the treatment. Now, people get confused. There's a lot of distinction, a lot of confusion over intention, belief, and desire. You can often intend to do what you don't desire, like answering your beeper at 3 o'clock in the morning. I hope all of you who are clinicians form that good intention, even though you don't desire to do it. You can intend even to do what you don't believe. I'm a New York Yankees fan. I don't have anybody to give as a good example of, sadly, this year, but in previous years I could say I could get up there and intend to hit a Mariano Rivera fastball without any belief that it was possible at all, right? And then I'll skip the other two to just get down to the case of Karen Ann Quinlan, a young woman who you may know died in the 1970s when her ventilator was discontinued, the first big case of that in the United States. What was the court decision allowing the doctors to do? What did the family go to court for? To discontinue Karen Ann Quinlan's ventilator. That's what they were aiming at. Did they believe she was going to die? Yes. Might they have even desired that, all things considered, she die? Yes. But what was their intention? Their intention was to stop the treatment that they thought was more burdensome than beneficial. And that's what they did. They stopped the ventilator, and many of you, I hope, know what happened. She started breathing. And they didn't say, oh my gosh, we failed. She's still alive. Let's get out a pillow to smother her. Right? What they did was to stop a treatment that they thought was going to lead to her death, but didn't. They thought that the treatment was more burdensome than beneficial. So I believe then that the distinction between killing and allowing to die, if you think about it that way, is actually defensible. And that's the way I think most clinicians think about it. That all acts of killing, we're creating a new lethal pathophysiologic state with the intention of making the person dead. If that's giving 150 milliequivalents of potassium into somebody's right ventricle, it's hard to say you have any other intention than to make the person dead, right? In allowing to die, what your intention is, in a narrow sense, is to discontinue the treatment. And if you do so for good reasons, then it's morally permissible. So I think the argument against sophistry is wrong. In fact, all the courts, including the U.S. Supreme Court, defend the distinction between killing and allowing to die. And much state legislature that allows the withdrawal of ventilators says that this is not an act of euthanasia. It's different. Okay? So most people, I think, can defend it when it's properly understood. But I also think that assisted suicide is bad medicine, bad ethics, and bad public policy. I think it's bad medicine because I think it, in the end, is clinically unnecessary. This is my argument against the argument for mercy. I challenge people to find, the medical burning lorry case, where we can, and I've been on radio talk shows, right, where people, call in and say, how can you be against assisted suicide, Dr. Sulmasy? I'm suffering terribly from this chemotherapy, and I've got this catheter that keeps getting infected, and I'm in, terrible pain. I say, well, why are you still getting chemotherapy, right? Who said you had to do that? Why do you still have that catheter in? That can be withdrawn. I'm all in favor of withholding and withdrawing burdensome treatments from patients. And if you're in pain, we can treat that pain. And if necessary, we can go to rhizotomies. We can do more than we've ever been able to do in 2,500 years of Western medicine to treat patients' symptoms. We can treat nausea. We can treat pain, even if necessary, to the point of sedating the person. So if we can go that far, how can anyone say that it is actually necessary from a clinical point of view for symptom control to engage in euthanasia or assisted suicide? And the surveys that you'll find internationally bear this out. Patients don't ask for euthanasia or assisted suicide because of refractory symptoms. They ask for it because they want to maintain control. They ask for it because they feel like they might be a burden. Or the Dutch have an indication called tiredness of life. It's just too much for me to keep going on. Those are the reasons that people give. It's not that you can find somebody whose symptoms can't, under any circumstances, be controlled. Second, I think it's bad medicine because it really represents an unprecedented notion of what a therapy is, right? It violates all the canons that we think about for good therapeutics in medicine. Anything else we do in medicine, we want to restore the person, right? So we're acting in such a way that we improve their lot at the end of whatever we're doing. Even if we make them suffer, even if we make them comatose for a while, it's with the intention that they come out of that, right, and be restored. Death is not restorative. Right? If that's what our aim is, which is the aim of the person who makes himself dead or herself dead, it's not restorative. Parsimony, right? I have a cartoon I sometimes show that says, before we try assisted suicide, let's give the aspirin a chance, right? That we want to try the measures that are the least important for patients first, and these less drastic measures, I think, can work. Even some pretty drastic ones short of assisted suicide, if necessary, like palliative sedation. It violates proportionality because the means and the end have to be connected to each other, not just the balance of burden and benefit. And secobarbital is not something that, if you look up in the physician's desk references, is an indication for tiredness of life. Right? We don't sedate people or kill them because they're tired of life in any other circumstance except when they're dying. Why is that? Why is that? Does medicine suddenly become something different in the last 4 days of a person's life or the last few weeks of a person's life than it is for all the rest of the time? Or therapy radically changes what it is? I don't think so. And then the last is I think it violates the canon of discretion, particularly when you're talking about the real indications for assisted suicide, which are not about, in typical cases, symptom control. I'm reminded of the ethicist from the 70s, Paul Ramsey, who said that the function of medicine is not to relieve the human condition of the human condition. I think sometimes we get frustrated when we can't fix everything because we're in the business of medicine to be fixers, right? But it's not our job to treat all the suffering of every kind that there is in the world. And if we have that much self-aggrandizement, that much hubris, I think we're in trouble as clinicians and our society will suffer. I think it's bad medicine because once this is on the table, it really does violate the very basic fundamental conditions of trust that are necessary for the existence of the very delicate physician-patient relationship. Okay? Patients disclose lots of things to us. They expose their bodies to us and their nakedness to us. And the conditions for trust since the time of Hippocrates, and I think before that, are these. That there are violations of that trust, that there have to be boundaries on the relationship in order to allow that trust. And those boundaries are these. I will not kill you. I will not divulge what you have told me in secret, and I will not have sex with you. Right? Those, I think, are the minimum conditions for trust that are necessary for the doctor-patient relationship. We don't say, I won't have sex with you unless you ask for it. Right? We shouldn't say, I won't kill you unless you ask for it. These are very firm boundaries, and they need to be there for the stability of medicine within a society. I worry deeply about the phenomenon of countertransference, the ways in which a clinician's own fears regarding death, disability, and disfigurement and suffering can, through the phenomenon of countertransference, subconsciously be then fed back to the physician by the patient as if they were the patient's own autonomous wishes, right? That the patient actually is, what the patient is actually doing is reading what other people, particularly the authority figure of the physician, thinks about them and saying, wouldn't I be better off if I was dead? And the physician says, yes, here's a prescription, right? That, I think, is troubling. And there are alternatives. We know that. Hospice and palliative care, the foregoing of life-sustaining treatment, adequate physician control, even to the point of sedation or respiratory depression, that we want to accompany patients as they are dying, But we don't ever want to ratify the idea that any patient, and maybe especially one who is dying, has lost all their value, and that therefore the world is better off and they are better off without them. That, I think, is a problem, and if you intend to make somebody dead or you help somebody to intend to make themselves dead, you have to concede that what you have thought is that they are better off and the world is better off without them. I think it's bad ethics for these reasons. The argument from dignity that you heard is all about what I call attributed dignity, but there's a distinction between attributed and intrinsic dignity. The people who are in favor of assisted suicide talk about dignity in terms of the value that one confers on oneself or the value that one might confer on another person. And there is no question that illness, particularly terminal illness, can render a relentless assault on the attributed dignity of a patient. They look different, right? They feel different. They are regarded differently by other persons. They are unproductive. They are dependent upon others. And illness brings this upon them. But the question about assisted suicide is whether that attributed dignity is all the value that they have, or whether there isn't underlying even the concept of attributed dignity an intrinsic sense of the value of the person, an intrinsic worth, what the philosopher J. David Velleman has called an interest-independent value, the value of the person has by virtue of being nothing else but a human being. Intending to make patients dead, and what all killing has in common with all bad cases of allowing to die, is the aim to make the patient dead. The aim is not that the treatment should end, but that the patient should end. Intrinsic dignity is not the value that we have by being in control or by virtue of how we appear to other persons or how productive we are or whether we are incontinent or not. Rather, it's the value we have by virtue of being the kinds of things that we are, human beings. It's a value that I recognize in every one of you, and I hope that you recognize in me, before I've even opened my mouth and told you what I think it means to me. Martin Luther King says he learned about this from his grandmother, who told him, "Martin, don't let anybody ever tell you you're not a somebody." That being somebody is the heart of ethics. It's the heart of this concept of intrinsic dignity, this value that everyone has simply by virtue of being human, and the reason that we respect their rights. Acting with the intention of making a somebody into a nobody or helping somebody else to make themselves into a nobody has that intention of robbing them of that intrinsic worth, of taking that worth away from them. And that is why the philosopher Wittgenstein, I think, intuited this in his own epigraphic kind of way. If suicide is allowed, he said, anything is allowed. Anything is allowed. This intrinsic sense of dignity is the heart of ethics. And that's why this question is so much more than about medicine. And the argument from liberty, which is the one we hear most commonly, is that this is my action and the government and no one else should tell me that I can't do this, and if I find a doctor who's willing to help me, that the government shouldn't prevent that doctor from doing it. Well, I would argue against that, that we are intrinsically social beings. There is no such thing as a purely autonomous human being who has no connections to anybody. In fact, we're more interdependent than we have ever been in the history of humankind. Just think of what happens when the internet goes down at UCLA, right? We are dependent upon each other in incredibly complex ways. Suicide is never a purely self-regarding act. It is always an act of communication. The world did me wrong, you did me wrong, and you're going to pay for it. There is emerging evidence of PTSD in families that have witnessed suicides and euthanasias of their patients. And there are evidence about the effects on physicians themselves, and even more literature, if you want to see it, of the effects in vets, in veterinarians, actually, of participating in euthanizing just animals, let alone human beings. There is also an emerging bit of data on suicide contagion. This study just published last year shows that the rates of suicide in the general population increase relative in states that have legalized assisted suicide relative to states that haven't. Suicide contagion. People get the idea that this will is in the air, it's something that will happen, and the vast majority of suicides are people who are psychiatrically ill. The more we talk about it, the more we make it reasonable. We say that there are reasonable suicides, the more that vulnerable those persons become to taking their own lives, when all of us would agree that they are not doing so rationally or competently. And lastly, I think it's bad public policy to legalize assisted suicide. There's first a slippery slope, a logical one. I'd say that every argument I gave for you that is put forth that justifies assisted suicide also justifies euthanasia. And I find it very hard for anybody to defend a distinction between those two. And the best, most honest proponents, philosophical proponents of euthanasia and assisted suicide, or of assisted suicide, are also proponents of euthanasia and don't think there's a difference. That would be Dan Brock and Peter Singer. They don't think that there's any difference between the two, because every argument you give to justify assisted suicide justifies euthanasia. And if you think that, we'll just justify assisted suicide, we won't justify euthanasia, you can't defend that. Legally, once you've legalized assisted suicide, this hasn't begun to happen yet in this country because, again, the forces that are trying to legalize it won't allow the cases to go forth. But once enough states have done it and the tide has turned, they will. Assisted suicide is going to necessarily imply, because of equal protection kinds of standards, the legalization of voluntary assisted euthanasia. Why is that? Well, even when I talk to doctors or even lay people, the first case they usually go, well, if I was paralyzed and had something like ALS, I'd want to have assisted suicide. Well, what's wrong with that? The person who's paralyzed can't take the pills, right? They can't take the pills. So that person has to be euthanized if they're going to die. So very, very shortly you will have within this country, if we continue on the road of legalizing assisted suicide, lawsuits that it's discrimination against persons who are paralyzed or can't take, for other reasons, can't take the pills. And we will move from assisted suicide in a heartbeat to euthanasia. And then we will move, I think, very quickly to at least non-voluntary euthanasia, at least non-voluntary euthanasia by surrogate decision-making, because, again, we think that someone who's lost decisional capacity still has rights to refuse treatment. Once you declare it a right to have assisted suicide, how is that person going to have the death that you think that they want or would have wanted, except by giving them a lethal injection? And so, for instance, in the Netherlands and in Belgium right now, demented persons, infants, and mentally ill people all have access to euthanasia and assisted suicide. There is also a psychological slippery slope that I don't think we pay enough attention to. Actually, one of the most chilling films I think I've ever seen was an interview with a Dutch euthanist who was asked whether it was hard. And he said it was hard the first time. It was hard the first time. Once you move past a certain position, this becomes easier to do. In fact, in Oregon, last year, 10% of lethal prescriptions were written by one physician in the state, right? Specializes in it and is proud of it. There are, distinct from a slippery slope, there are arguments that can be mounted about abuse, fear of economic abuse and social abuse. It is the case, for instance, that the number of cases has been steadily increasing in Oregon and Washington. Numbers are still small, but the trend is basically ever upward. There is also an attitudinal link that I was able to look at a few years ago, that physicians who are in favor of of legalizing assisted suicide tend to be people who also are in favor of health care, the most cost-effective health care possible. Now, I'm not saying those are causal, that one causes the other. They're not making people die to save costs, but what I think is it's a kind of rationality that people have. Well, cost-effective medicine is rational, suicide is rational. It just sort of goes together, but in ways that I think are troubling. And then there's the possible social abuse of this. Again, out of it's less than I think 5% of patients and sometimes in some cases even less than that in Oregon who get psychiatric evaluations. Linda Ganzini, who's going to be coming here, can tell you that up to a third of patients actually test positive when they've been able to do it for depression. But they're not being seen by psychiatrists. Moreover, I think that patients will soon get the idea that they have a duty to do this, that they have a duty to die by this way. Once this option is on the table, the default switch flips, right? Right now, the default is continued life, and you've got to make a good case for discontinuing the life-sustaining treatments for the person. But if assisted suicide is legal, the question everybody will be asking, and they'll be asking you, as well as your loved ones, as well as your patients, why haven't you done it yet? Why haven't you done it yet? Once the option's on the table, that's where the conversation will go. So, I believe that the distinction between killing and allowing to die is defensible. I believe that we can mount arguments opposing assisted suicide as bad medicine, bad morals, and bad public policy. If you want more about it, I'll invite you to go to a debate I did with Peter Singer. If you've ever watched Intelligence Squared, we did this on November 13th, 2014. It's an hour-and-a-half debate. You can, they're all archived. You can look them up. We actually, my colleague Laura Finlay from the UK and I actually won the debate by persuading the most people who were undecided, which is the best thing that you can ask for in a debate. But with that, I've left at least 10 minutes for further debate and discussion. I thank you for your attention. And again, please don't kill me. I'm giving you a strong case against doing that. But I hope that we can engage in a respectful debate and dialogue about this question. So, thank you. Yes.
You said that people that we don't value those who assist in suicide.
Mm-hmm.
But I've always thought of it sort of as the opposite, where we tend to value people and their feelings more if we assist in suicide versus us assisting or assuming that they want to live based off our own beliefs, based off what we do, based off religious texts or something like that.
I'll repeat the question. The question is, isn't it actually more a way of valuing the person who has asked for assisted suicide by assisting them with that, rather than my contention that we have to act with the premise that they have lost their value? What I'm suggesting is that there are no disembodied persons, right? So the value of the human being and the value of their being alive are coextensive, and that to say that we intend to make them dead or assist them in making themselves dead, they have to come to the belief that their life is no longer something of value, that they, as an embodied person, no longer have value. And that we have to share in that intention if we want to assist them in doing that. And that's independent. This is the sort of interest-independent value, right? It's the value they have. The reason we would typically want to respect your wishes is because we first respect you as a person, right? And that's the reason why we do so. And what a philosopher like David Velleman will say is we've got to probe further. And Velleman is not a religious person, so this is not a religious argument. He says there is an interest-independent value to each and every human being. And that's why, and he thinks that's the bedrock of ethics, and that's why we can't act with the intention of making them dead, because then they have no existence and they don't have that value as persons, and they have no preferences to respect anymore. Yes?
Putting aside the arguments for what was mentioned in society, what I don't understand about this whole legislative process that's occurred both here and abroad is, why do healthcare providers have to be involved? Why is the movement not saying, I need to certify in some matter, stamp or something like that, that I have some bad disease that I'm dying from, and I go to the local CVS and they give me the prescription? Why is the movement demanding that physicians and others be involved?
Yes. So the question, again, I'll repeat it for those who didn't hear. Maybe there are some who are watching, I guess, on closed-circuit television. The question is, why has the movement and the legislation asked that this be physician-assisted suicide rather than other-assisted suicide? And I think it's a good question. My best guess, I don't know. My best guesses are these. One, that patients presume that physicians will have better expertise. They'll be better at it than others. So, for instance, it's one of the reasons why those who are in favor of capital punishment and have that in certain states want to have physicians participating in it to make sure that it's not botched, that it's done as well as possible, and that the physicians would have the expertise for it. And second, probably more importantly, I think in broad way, it's a search for approbation, societal approbation for their desire to do this, and that they think that cloaking it in the mantle of medicine gives them the maximum kind of social approbation that they're seeking for it. But I agree with you that it's actually not necessary that physicians do that, and I'm not in favor of it, but I think it would be better if there were other people doing it than physicians, because of all the things that I raised about what it does to the doctor-patient relationship, the meaning of medicine, etc. I would be still opposed to it, but I think that would be better than having physicians doing it. Yes, the way back first, yes.
One of the arguments we made was there's alternative treatments most of the time. But there's been a movement in the Netherlands for psychiatric illness as well as dementias. In those cases, there may be many fewer alternative treatments. So if that's the case,
Yes.
what do you
Yeah. So that's a good question. The question is, what about the cases in the Netherlands now of refractory depression or other psychiatric conditions that seem to undermine the argument that are alternatives? Well, first of all, the people who are first pushing this are not pushing it for psychiatric cases, right? And in fact, currently in all the legislation, it has to be for, at least in the U.S., has to be for somatic illness, not for psychiatric illness. So that the argument stands at least within that. Second, in terms of refractory symptoms for someone who is depressed, I keep trying for those persons. There's no sense in which, and some of those persons will eventually succeed, for instance, in killing themselves. But I think, again, for the kinds of reasons that I've suggested, we ought to keep trying. There are lots of things that we're not very good at in medicine. I don't know about where this hospital is located in terms of the number of injection drug users that you treat, but certainly if you probably treat a lot of alcoholics, if not a lot of injection drug users. That chances of actually getting somebody who's been hospitalized, who's overdosed on heroin or gone through the DTs, of getting sober, right, are small. They're very small. But doesn't mean I don't keep trying, right, to try to treat those things, and that there isn't, in the end, some possibility that those things would work. And then lastly, I would say that once you most people think of the psychiatric indication as an indication of the slippery slope, actually, rather than a primary justification. So, yes, in the way back. Yes. And there was somebody on here too. I know somebody. I'll get to you next. I'm sorry. Go ahead.
I'm not sure I followed your argument about the default switch being flipped to legalization of assisted suicide. If physicians are still available as kind of a filter or catchments, if you will, for patients who are seeking this, what is it about that interaction or the legalization of this practice that would switch the default in the other direction?
Yeah. Now the question is to clarify more what I meant by flipping the default switch towards this action, and wouldn't physicians still be in fact social arbiters? That could be a protective device. First, I think that putting, as was said before, putting the physicians in the position of being that kind of a judge is a real problem. Right? Part of this gets to the other question that was just asked before of why is it that physicians have to be in the position of judging whose suffering is worthy of this? And that's the position they're put in, because the physician has to justify that and has to vet the person's request. And second, in terms of the general sort of tenor within society, in which physicians are part. Right? We are not isolated from the rest of our society. This just casts a huge shadow over that relationship. We're not isolated from the rest of society. So once the option is on the table for the patient, whether it's family members, whether it's insurers, whether it's the physician, there is this inkling sense in the back of if that person's suffering is terrible, the question of whether or not this should be offered to them comes up. The question of whether there's countertransference and the physicians, as I said before, own problems dealing with these questions becomes transferred subconsciously to the patient. All of this, I think, conspires to put the patient in the position of having to defend the fact that they are asking for continued treatment. And this is another kind of anecdotal example, but you may have heard the case from a few years ago from Oregon of a woman who was denied a $4,000 a month cancer treatment that might have extended her life 6 months because she was on Oregon Medicaid, and the denial letter listed all of her options, including the Oregon Death with Dignity Act. That's on the table. That's the default switch being flipped. I'm sorry. Yes. Yes. First. Yes.
Just to state facts, it's not been a runaway situation in Oregon.
Mm-hmm.
But just recall in the first 18 to 19 years of experience, only 1,545 prescriptions were written.
Mm-hmm.
981 people executed their prescription. In the last year of experience, several years ago, the number of people who executed their prescription in that calendar year compared to the number of people who died per year in Oregon, which is 35 or 40,000 a year, this activity, which I'm not making a judgment at the moment, but I think people have to leave hearing some important facts, only represents 0.3%.
Yes. Yes. It is correct that in Oregon this is still a very small number of persons. In fact, this is one of Zeke Emanuel's main arguments, that this is for the 0.1% or 0.3% of the population that really wants this. The problem is that once it generalizes, the experience in Netherlands goes back into the 80s, right? This is very early still in Oregon. Do you know what the percentage of people who die from euthanasia is in Belgium right now? It's 5%. 1 out of 20 people die by euthanasia in Belgium. I think the argument that we can control it, this is the United States, it won't happen here, is a very tenuous argument, in my view. Yes?
I was just going to ask you, how paternalistic do you think it is to say, I can value your life better than you can value your life. You don't value it enough. I'm going to give you more value to it with your
The question is whether the view I'm presenting is paternalistic. What I'm suggesting is not that I'm valuing that person's life any more than they are. What I'm suggesting is that neither of us can place a value on that life. This goes back to Immanuel Kant, right? Kant's view is that every person is an end in themselves and never a means only, whether for themselves or others. And that's the bedrock of ethics. So it doesn't matter. Your value and my value and the person who's asking for assisted suicide isn't up to me or up to you or even up to them, right? It is the bedrock of what ethics is to recognize the intrinsic value that they have, which we don't create. I'm not creating it, they're not creating it, you're not creating it. And that's the argument here. So that Kant's own argument is that the person who is doing so, right, is treating themselves as a means and not an end, as a means only and not as an end in themselves. And what I'm suggesting is that the bedrock of ethics is that everybody is a somebody, everybody is an end in himself or herself, independent of what I think. Doesn't matter what I think. Doesn't matter what you think. Doesn't matter what the patient thinks. If we are to have a system of ethics at all, we have to have that value of the person, which is independent of all of us, as the bedrock. That's the argument. So it's not subjective from me, subjective from them. Yes?
I just have a comment, which I think is a very rational argument. I'm not sure that I would agree with many things, although some. But one of the things that really struck me is that when you talk about the issue of nobody versus somebody, and I think that's a very valid, the concept of, I think everyone wants to be somebody, and I don't think anyone wants to be nobody. But I don't think that somebody becomes a nobody in death.
Mm-hmm.
And I think that that's a really important piece in this.
Mm-hmm.
And that to diminish this into thinking that upon someone's death, that their value is ended.
Mm-hmm.
It feels naive to me
Mm-hmm.
in terms of
Mm-hmm.
in terms of the whole of life,
Mm-hmm.
which is the natural cycle of life and death.
Now, it's a good point. The question is whether when someone dies, they become a nobody. That's not the argument I'm making, right? I'm not saying that they become a nobody. Part of what you're suggesting is the ways in which when someone is dead, that they do continue to have value, right? And I think that's also true. Certainly, many religions will agree with that. I was trying to make a secular philosophical argument because the philosophers like Dan Brock, when he's asked to depict what death means, and I was at a conference with him, he just drew black all over a piece of paper. That's what death is. It's annihilation. It's nothingness. So from a purely philosophical point of view, most philosophers will take that as true. If you want to grant me the concept of an afterlife, then you're going to talk about a religious argument, potentially. No, good. So I think religious arguments can have another, I was trying to stay away from. The only other conception, you may want to look at a recent book called Death and the Afterlife by a secular philosopher, Francis Schaeffer, who's talking about the ways in which our even when we die, right, our memories persist, other things about us persist, how we've acted in the world continues to persist, and it's a kind of sort of secular philosophical version of an afterlife. And I believe all those things are true, so that when it's one of my main arguments about why it's immoral for a house officer to practice intubation without consent on somebody who's just died, right? Because there's something about that person that's still there when they're dead, and that value for me persists. What I am suggesting is that acting with the intention, right, of ending that person's life is to separate them from their value, which is what death is, and that is where I think it's always wrong.
And I think what I'm talking about is a psychological issue, and I don't think that you're actually separating out, removing someone to a nobody by the process of making them, use your words, be dead.
Mm-hmm.
And I think from the other perspective,
I'm not sure I understand whose psychology. But whose psychology are we talking about? The patient's or the other person's?
I think everyone's psychology.
Mm-hmm. Mm-hmm.
Everyone's psychology. Because I think
Yeah.
people imagine their own death.
Mm-hmm.
They think about their
Yeah.
own death.
Yeah.
There's a psychology to that. And I
Yes.
think what happens to the family, there's a psychology to that.
Yes.
And as you cited, that PTSD often happens when people witness
Yeah.
an assisted death.
Mm-hmm. Sure.
Families develop PTSD symptoms around death.
Mm-hmm.
And I don't think that there's been particular research that has separated out those different types of deaths and the different kinds of.
Yeah. Yeah. Again, I won't disagree with you that there are psychological effects that we all have on each other, and that those persist after we're dead. What I thought you were, or that someone could have wishes about what would happen to them after they were dead. Those are different from the question of whether the person still exists or not, right? And again, unless you want to grant some conception of an afterlife. So. Okay. Well, thank you for all of your attention and very good questions. Thank you.